Our Updates in Hospital Medicine webinar. Thank you for our speakers for joining us as well. So I'm a member of the Washington ACP Executive Council and a co-chair of the Hospitalist Council along with Deepthi Mani, and we're excited to put on a few different webinars over the next few months. Before we get started on this one, I just wanted to say our next one is going to be on September 9th, and that'll be Goals of Care discussions for hospitalists, so another hospitalist focused virtual kind of workshop. So that'll be interesting if you can join that. I'll briefly introduce our speakers. So first is Dr. Susie Glass. She is a hospitalist at the Puget Sound VA and a University of Washington clinical assistant professor. And then Dr. Angela Zhou is a hospitalist at Harborview and a University of Washington clinical instructor. And Dr. Meghaan Hawes is also a hospitalist at Harborview and is a University of Washington clinical assistant professor as well. They are all experts in updates in hospital medicine because all of them participate in a UW Medicine Hospital Medicine Updates in Hospital Medicine group that presents quarterly to the residents and the different hospitalist groups across our system. So they are the most up-to-date, I think, of all of us. So we're excited to learn from them. We will take questions at the end of the talk. There should be enough time to answer all your questions, and I will help keep track of any questions in the comments throughout the session so that we can address all of them at the end. On to you, Susie.
All right, thanks so much for that introduction. So today, kind of as Dr. Gulabhati mentioned, we all of us are kind of a group of hospitalists who participate in this UW Medicine Hospital Updates in Hospital Medicine group, and we do quarterly lectures similar to what we're presenting today, where we really try to focus on practice changing and confirming studies from a variety of journals. Today specifically, we're going to be talking about relevant studies to hospital medicine published in the last year, looking from April 2020 to
So this test is
we actually specifically decided to leave out anything related to COVID, somewhat due to kind of ongoing COVID fatigue, but also because we thought this offered a great opportunity to focus on some studies which may have been overshadowed by the ongoing global pandemic. So we will go kind of through each study in detail, and then at the end provide key takeaways for each topic. And yes, we will happily answer questions at the end and monitor the chat box. So please make sure to ask any questions that come up. As a matter of formality, we don't have any financial disclosures or conflicts of interest. And we'll go ahead and start. So first topic is going to be about aspiration pneumonia and just a little bit of background. Aspiration community-acquired pneumonia is about 10 to 20% of all community-acquired pneumonia cases. And it's important because it portends a significantly higher mortality than community-acquired pneumonia alone. And as all of you are, I'm sure, aware, the IDSA ATS put out new community-acquired treatment guidelines, and they recommended against the empiric use of anti-anaerobic antibiotics for patients with aspiration pneumonia, and recommended they only be used if there's a suspected abscess or empyema. So this study came out in CHEST in January of this year, and they were specifically trying to look at the prevalence of anaerobes in aspiration community-acquired pneumonia, as well as the empiric use of anti-anaerobic antibiotics. It was actually a secondary analysis of a previous study that was a large multi-center international cohort study looking at the prevalence of MRSA in community-acquired pneumonia. It's called the GLIMP trial. In it, there were 2,600 hospitalized patients with a clinical diagnosis of community-acquired pneumonia and some form of microbiology bacterial testing. The diagnosis of community-acquired pneumonia is as we kind of diagnose it here in the United States. So someone had to have signs and symptoms of a pneumonia, as well as a focal consolidation on imaging. And then as an additional safeguard, they wanted every patient to have a documented fever of 38 degrees C or higher. They subgrouped the patients into one of three categories. So patients with aspiration pneumonia, which was a clinical diagnosis by the treating physician and represented about 7% of the patients in the study. And then community-acquired pneumonia with or without aspiration risk factors. Those last two groups, they actually determined using a multivariate analysis of the patients in the study. So they compared patients who had a clinical diagnosis of aspiration pneumonia versus those who did not, tried to find any significant patient characteristic differences, and then used those risk factors to kind of create a more objective category to help capture any patients who were missed by that subjective clinical aspiration diagnosis. So the big ones that stand out and are as expected that increase the risk for aspiration were neurologic diseases like prior stroke or known dementia, patients who were underweight, bedridden, lived in a nursing home, or receiving tube feeds. And then every patient had some microbiology sample performed within 24 hours of admission prior to antibiotic administration. About half of those were sputum samples, and then there was a smattering of other samples obtained that was left up to the discretion of the treating physician. And their primary outcome they were looking at was, again, prevalence of anaerobes in these samples, and then the frequency of anti-anaerobic antibiotic use. So what did they find? Well, overall, the prevalence of anaerobes in community-acquired pneumonia is quite low. So in aspiration pneumonia, it was 0.5%. When there was community-acquired pneumonia with aspiration risk factors, that went down to 0.3%. And then without risk factors, it was 0% in this study. Those numbers increased when you took out patients who didn't grow anything in culture. But overall, there was no significant difference between these three groups with respect to anaerobes. The one place they did see some differences were when they further subcategorized patients based on the severity of their pneumonia. So if we look at this graph from their study, looking at that last group of columns, each column represents one of the subgroups. And then these are patients who were categorized as having severe community-acquired pneumonia. Those with an aspiration community-acquired pneumonia had increased gram-negative bacteria and significantly decreased gram-positive bacteria, specifically strep pneumo, compared to the other two groups. And that's even further highlighted in these graphics. So this is just the aspiration pneumonia patients in the study, again, separated out based on severity of their pneumonia. And in the patients with severe pneumonia, anything with an asterisk was statistically significant. So increased gram-negative bacteria, decreased gram-positive bacteria. And although you can see there's little slivers of fat for the anaerobes, there was no statistically significant difference between those groups. As far as antibiotic prescribing patterns, more than half of the patients with community-acquired pneumonia in this study, so all the patients, received anti-anaerobic coverage. And that's specific anti-anaerobic coverage, things like clindamycin, metronidazole, or really broad spectrum big guns like the carbapenems, piperacillin, tazobactam, and sulbactam, et cetera. That number increased to about 3/4 of all the patients who were diagnosed with an aspiration community-acquired pneumonia. So there's definitely some limitations with this study. Few strengths, it's pragmatic, a real-world design. And I appreciated that they tried to create a little bit more of an objective aspiration risk factor category to account for patients who might have been missed by that aspiration pneumonia clinical diagnosis. But it is an observational study. They didn't have a standardized definition of aspiration pneumonia or any way to objectively evaluate aspiration. And then the other big concern is that it's a secondary analysis of another study, which always makes us a little bit leery that there could be potential false positive results from repeated analysis of the same data. But at least in this study, it's a very similar outcome, even though it wasn't the true original study design. So what can we take away from this? Well, the prevalence of anaerobes in community-acquired pneumonia, regardless of aspiration or aspiration risk factors, is very, very low. In patients with a severe aspiration pneumonia, we should really be targeting gram-negative bacteria with empiric coverage, specifically Pseudomonas, Klebsiella, and E. coli. And then, unfortunately, despite those kind of recent guideline updates with IDSA and ATS, anti-anaerobic antibiotic are still overused currently in clinical practice. All right, so along the lines of antibiotic stewardship, I just wanted to briefly mention this clinical guideline update that came out in Annals in April last month. It was actually reviewing kind of all of the best evidence we have for short courses of antibiotics in common infections. And this is one I would actually recommend you read if you have a moment, but I'm just going to quickly summarize some of the key highlights. So they reviewed 4 different infections. The first was acute bronchitis, which was really just patients with a COPD exacerbation, and recommend a 5-day treatment course of antibiotics. For community-acquired pneumonia in immunocompetent adults, they agree with the IDSA ATS guidelines, recommending a 5-day course of antibiotics, but extending that therapy if the patient has not clinically improved by day 5. In non-pregnant adults with uncomplicated pyelonephritis, the recommendation for treatment duration is dependent on the antibiotic prescribed. So those who receive a fluoroquinolone should get 5 to 7 days of antibiotics. And if you're prescribing trimethoprim sulfamethoxazole, it's a 14-day course. And then the last infection is non-purulent cellulitis. And the guidelines recommend a 5 to 6 day treatment course of an anti-streptococcal antibiotic. Again, similar to community-acquired pneumonia, and that you extend treatment if the patient hasn't improved after 5 days. All right, and my last study, but still kind of in the pulmonary realm, is about the prevalence of PE and COPDs. So a little bit of background, many of you probably remember the study published in Chest in 2017 that estimated the prevalence of PE at 16% in patients with COPD exacerbations. The challenge with this meta-analysis was that it included primarily patients with an unexplained COPD exacerbation, and it had a really wide confidence interval of about 8 to 26%, which makes it a little bit challenging to interpret. And then the other big problem was that 1/3 of the patients who were diagnosed with a PE in this study had a subsegmental PE, and it's unclear if those were clinically significant. So this study came out in JAMA in January 2021 this year, and they were looking at the prevalence of PE in all patients with COPD exacerbations who were hospitalized. It was a multi-center prospective cohort study done in France of 740 patients hospitalized with COPD and worsening respiratory symptoms. They used what we would kind of categorize as a COPD exacerbation with at least a change in 2 of the 3 cardinal symptoms, so very similar. And every patient underwent a physician assessment on admission, basically trying to figure out the physician's suspected likelihood of a PE in each patient. And then they did a standardized algorithm to evaluate VTE for each patient. Their primary outcome was PE diagnosed within 48 hours of admission, and then they had a secondary outcome looking at PE diagnosed 3 months later to try to account for any potential missed PEs during this index hospitalization. So this is their algorithm from the study. They used the revised Geneva score, which is something I wasn't familiar with, but it's very similar to a modified Wells score, and I've included it here on this slide for your review. Any patient who had a high Geneva score automatically underwent CT-PE study with bilateral low extremity duplex. In the patients with a low to intermediate score, they received a D-dimer, and that further separated whether or not they had VTE testing or did not require additional testing in this study. So what did they find? Well, in this study, the overall prevalence of PE was much lower than what has been reported in some other studies. It was down at about 6%. Again, that's all comers, anybody with a COPD exacerbation who's hospitalized. It increased to closer to 13% when there wasn't a clear etiology for the COPD exacerbation, more consistent with some of these previous studies. Physicians, unfortunately, did not fare very well in this. So in patients who were suspected to have a PE, only 10% actually did. And in those who were not suspected to have a PE, 3.2% actually ended up having a PE with their algorithm. And then in 3-month follow-up, they found 5 patients who had a missed PE. So these were patients who were categorized as having a low likelihood of PE and then a negative D-dimer. 3 of these patients, they actually reported died of their PE. So some strengths of this study is probably at least a better prevalence estimation for all patients admitted with a COPD exacerbation. And I appreciated that they included this 3-month follow-up to try to make sure that they accounted for any potential missed PEs as a part of their study algorithm. There were definitely a fair number of limitations. So again, this is not a randomized control trial. The generalizability is a little challenging because there were low numbers of patients who had a mild or severe exacerbation, and it was overall a very non-diverse patient population. It was primarily older white men. They also had a decent number of study protocol violations without clear explanation as to why. So in patients who had a positive D-dimer, a fair number didn't go on to receive appropriate VQ or CT scan, and then even more patients didn't receive the appropriate duplex. And then the last and maybe the biggest limitation is that it really still doesn't answer the question that's maybe most clinically relevant to us of who and when we screen for VTE. So again, what can we take away from this study? Well, the prevalence of PE in patients hospitalized with acute COPD exacerbations is still really, really high, and particularly when there isn't a clear etiology for their exacerbation. So for those patients, it's really reasonable to consider screening empirically. And I think this really highlights that we need better studies that help us create an appropriate screening tool for this patient population so that we can better evaluate patients for VTE and appropriately select those patients to reduce exposure to CT scans, and then also make sure that we're capturing all of these patients. And that's it for me.
Okay, so try to, oh, there we go. So I'm going to be talking about a couple of studies about indications for DOACs. The first was from New England Journal of Medicine last April. This is apixaban for the treatment of venous thromboembolism associated with cancer, asking the question whether apixaban is as effective as low molecular weight heparin in these patients. For a little bit of background, so historically, there have been a number of studies showing that low molecular weight heparin have efficacy compared to warfarin in VTE patients who also have cancer. And so low molecular weight heparins have been the primary treatment of choice. There have been a few studies of DOACs in this population. I just wanted to highlight 2, both of which were published in 2018. The SELECT-D study looked at rivaroxaban compared to dalteparin and showed that 6 months of rivaroxaban resulted in reduced recurrence of VTE 4% versus 11% respectively. The rate of major bleeding was similar between groups, but there was an excess number of clinically relevant non-major bleeds with rivaroxaban, 13% versus 4% for dalteparin. Most of these were GI bleeds. In the Hokusai VTE cancer trial, they compared edoxaban with dalteparin and showed that edoxaban was non-inferior to dalteparin in prevention of recurrent venous thromboembolism. However, the rate of major bleed was higher, 6.9% in edoxaban versus 4% in dalteparin. And again, this was mainly due to GI bleeds. And so in this study, comparing apixaban with dalteparin, this was a multinational randomized open label non-inferiority trial. The population were patients who had cancer, who had symptomatic or incidental proximal DVT or PE. This study excluded patients who had primary brain tumors or known intracerebral metastases and acute leukemia. That wasn't true with the prior 2 studies that I mentioned. The intervention again was oral apixaban versus subcutaneous dalteparin for a study period of 6 months. And the primary outcome was looking for recurrent VTE during the trial period or major bleeding. And so this table of their results as far as primary outcomes. So they showed that oral apixaban was non-inferior to subcutaneous dalteparin with similar incidence of recurrent VTE in both arms of the study. And they further broke it down into recurrent DVT versus PE and fatal PE, and with similar event rates in both arms. For their primary safety outcome, there were also a similar frequency of major bleeding. And here they broke it up between GI bleeding and non-GI bleed. And again, it was similar between both groups. GI bleed did still make up a pretty large proportion of total major bleeding events. Moving down into their secondary outcomes, there were no major differences between the apixaban group and the dalteparin group in terms of non-major bleeding, death from any cause. There was slightly higher event-free survival in the apixaban group, but overall, no huge differences. And so the strength of the study was a large randomized trial with a well-balanced study populations, and there was blinded adjudication of outcomes, which was important because one of the limitations was that this was open label. And some questions about the generalizability. So the exclusion criteria did not enroll patients who had primary or metastatic brain tumors or acute leukemias. And the prior studies I mentioned did not have this as an exclusion criteria, but looking at the actual numbers, patients with brain tumors still made up pretty small percentage of enrolled patients. So the safety of these agents in that population is still uncertain. The big take home here is that oral apixaban seems to be a non-inferior to subcutaneous dalteparin for the treatment of cancer-associated VTE. And in the study, it does not seem to be associated with higher risk of bleeding. So the next trial of DOACs is the study from New England Journal of Medicine published last November. And it's rivaroxaban in patients with AFib and a bioprosthetic mitral valve, asking whether rivaroxaban was as effective as warfarin in these patients. So just for a little bit of background, I pulled this figure from the 2020 American College of Cardiology, American Heart Association guidelines for the management of patients with valvular heart disease. And in patients who have valvular heart disease and AFib, for those who have rheumatic mitral stenosis, the recommendation is for long-term vitamin K antagonists. For patients with native valve disease that is not rheumatic mitral stenosis, the guidelines stated that NOACs could be an alternative agent. And for patients with bioprosthetic valves, they divided it into those who were a little farther out from their procedure, greater than 3 months, versus within 3 months. For those who are a little farther out from procedure, a NOAC or a vitamin K antagonists could be used. And most of this data is based on meta-analyses or subgroup analyses of studies where patients with bioprosthetic valves were included. Most of these studies excluded patients who were within 3 months of valve implantation. So there is much less data in that time period. And it's also thought that those first 3 months is higher risk in terms of strokes or other events. And so for those patients, current guidelines still recommend anticoagulation with warfarin. The other group that isn't on this figure are patients with mechanical heart valves. And for those, they still recommend vitamin K antagonists. I think there was a pilot study with a DOAC which was ended early because of an excess of events in the DOAC arm. So still requires further study. So for this study, rivaroxaban and AFib and a bioprosthetic mitral valve, it was a randomized non-inferiority trial, open label with blinded adjudication of outcomes. The population was adults with permanent paroxysmal or persistent AFib or A-flutter who had a bioprosthetic mitral valve. And one of the things to note is that patients for this study were eligible anytime at least 48 hours after mitral valve surgery. So they did enroll patients who were pretty early on after their surgery. The intervention was oral rivaroxaban versus dose-adjusted warfarin for a target INR of 2 to 3. And the primary outcome was a composite of death, major cardiovascular events, or major bleeding up to 12 months. So for their primary outcome, this is the Kaplan-Meier curve, and they found that rivaroxaban was non-inferior to warfarin in that composite prevention of deaths, major cardiovascular events, or major bleeding. To break it up a little bit more as far as their secondary outcomes. So overall, very similar outcomes between the rivaroxaban arm and the warfarin arm. So deaths from cardiovascular cause or thromboembolic events, 3.4%, and rivaroxaban 5.1%, and warfarin, no significant differences. For stroke, there was slightly fewer events in the rivaroxaban arm, 3 events, 0.6% versus 2.4% in the warfarin arm. But it's difficult to really make definitive conclusions because their event rates were so low, but it did seem to trend towards favoring the rivaroxaban arm. Deaths from any cause were similar. Incidence of valve thrombosis, very low in both arms and similar, and hospitalizations for heart failure. No major differences. Breaking it up into the subgroups, overall, again, pretty similar data between rivaroxaban and warfarin. The groups that seem to favor rivaroxaban a little bit more included those who were on antiplatelet therapy at baseline and those who were in that early time point, less than 3 months after mitral valve implantation. The caveat is that these patients made up a pretty small portion of the total study population. So about 20% of patients were within 3 months since their mitral valve implantation. And then the total number of events within that group were also pretty low, but certainly warrants further study. So some strengths for the study. It was a randomized prospective study. It was quite a large study population, well balanced with baseline characteristics, and again had blinded adjudication of results because it was open label. Some other limitations. So they only studied bioprosthetic mitral valve, so not generalizable to mechanical valves or rheumatic mitral stenosis. And there are studies currently in progress in those populations. And more studies are needed to assess the efficacy of DOACs in that early time point after valve surgery. The main take home is that rivaroxaban is non-inferior to warfarin for patients with AFib and a bioprosthetic mitral valve. I will stop there.
All right, thanks, Angela. So shifting gears, we're going to be talking about inpatient hypertension. And our current guidelines for management of chronic hypertension are based on well-controlled outpatient clinical settings with really controlled blood pressure measurements. And unfortunately, similar evidence to support treatment of inpatient hypertension in the same way as chronic hypertension is lacking. We just don't have the data. We know clinically there's a variety of contributing factors to high blood pressures in the hospital, things like pain, anxiety, nausea, independent of underlying hypertension. And the relevance of treating those high blood pressures in those clinical settings when maybe it's an adaptive characteristic, we just don't know. We also do know that harms associated with chronic hypertension, things like cardiovascular disease, stroke, and chronic kidney disease, takes many decades of exposure to blood pressures to develop these complications. However, despite knowing that, recent survey studies have shown that there's still a strong physician urge to treat hypertension in the hospital, even when blood pressures are only mildly elevated or patients are asymptomatic. And that's also the case for asymptomatic hypertension at really elevated pressures with things set up in the hospital like rapid response criteria to merit transfer to the ICU, despite not great evidence to really know that treating those pressures in an asymptomatic patient is necessary. And furthermore, the long-term clinical benefits of treating high blood pressure in the hospital or intensifying somebody's outpatient chronic management at the time of their discharge are unclear. So there was a paper that was published in JAMA Internal Medicine in April of this year that sought to look at this issue of treatment and outcomes of inpatient hypertension among adults with non-cardiac admissions. And they were specifically looking at, for these patients, is treatment of hypertension during the admission or intensification of their outpatient antihypertensive treatment at discharge associated with better outcomes. So the design of the study was a retrospective cohort study, and it included 10 hospitals in the Cleveland Clinic system. Again, they enrolled patients or looked at patients who were admitted to the medicine service, excluding admissions for cardiac diagnoses like heart failure or ACS, or admissions within 30 days for a stroke or ACS. They also excluded pregnant patients and patients with really short or long lengths of stay. The exposure that they looked at was any acute hypertension treatment, and they defined that as the administration of an IV antihypertensive or a new oral antihypertensive class that wasn't part of the admitting med list of the patient. And then the outcomes that they looked at were acute kidney injury, MI, stroke, or a composite of all three. They also looked at stroke and MI occurring within 30 days of discharge, blood pressure control up to 1 year after discharge, and medication intensification at discharge. They were able to actually look at a lot of patients. They had a total of about 23,000 adult hospitalized patients for non-cardiovascular diagnoses that they included in their analysis. There was the patient mean age was about 65, a little over half women, and close to 70% white. Of those patients, 78% had at least one hypertensive blood pressure during their hospitalization, and about a third received treatment. Of the treated patients, 74% had only oral treatment, and about 26% received at least one dose of an IV antihypertensive with or without new oral class added. Treated patients, they found, had significantly more comorbid CKD and hypertension and less asthma and COPD. This is a chart comparing treated and untreated blood pressure measurements. And again, of all the hypertensive readings, only 8% led to treatment. Not surprisingly, higher blood pressures were more likely to be treated. And you can sort of appreciate this in the increasing rate of treatment as the diastolic and systolic blood pressure range rises. Although interestingly, even at really severely elevated systolic blood pressures of at or greater than 220, treatment was only given less than half the time, 47%. Also among treated patients, their prior to blood pressures were more often elevated. For their analysis of inpatient outcomes of acute kidney injury, MI, stroke, and the composite, they matched about 4,500 treated patients to untreated patients using propensity matched scores. And there were no significant differences in any of the variables they included, such as demographic data, smoking status, comorbidities, length of stay, et cetera. And they found that patients who received antihypertensive treatment were more likely to experience complications of AKI, MI, or the composite outcome of all three, compared with the propensity matched patients who didn't get treatment. They didn't see any differences in the stroke outcome alone. And then when they looked at the same outcomes for treated and untreated patients by the mode of administration of hypertension, antihypertensive IV or oral, as well as the systolic blood pressure interval of the index blood pressure, They found that both IV and oral medications were positively associated with that composite outcome altogether, as well as specifically MI and AKI. And there was an increased odds of all three outcomes when they looked at each blood pressure interval, both moderately elevated blood pressures and more severely elevated blood pressures. Again, stroke didn't differ by treatment route or index blood pressure. In terms of their post-discharge outcomes that they were looking at, 9% of the patients in their analysis had a new class of oral antihypertensive prescribed at discharge. At 30 days post-discharge, there were actually similar rates of MI or stroke with and without intensification at discharge. And when they looked even further out at a year, there was nearly identical blood pressure control with and without intensification at discharge. So in terms of the strengths of this study, it was a really large study, again, almost 23,000 patients, and it was across several hospitals within one hospital system, but probably a good variety of patients included. They also had a large number of well-balanced patient characteristics when they did their propensity match analysis. Compared to other studies that have looked at adverse outcomes of treatment of hypertension in the hospital, the interesting thing about this study is they actually looked at end organ damage associated with treatment, things like the AKI, MI, and stroke, or also associated with hypertension, rather than just surrogates for hypotension-related harms. Other studies have looked at things like boluses of fluid given or rapid reductions in blood pressure or tachycardia as surrogates for adverse outcomes of treatment of hypertension. This was also the first study that looked at oral antihypertensive treatment outcomes in terms of adverse outcomes. Other studies have looked a lot at IV treatment in the hospital, but this included both oral and IV, which was helpful in terms of adding to the data. In terms of the limitation, the retrospective design could potentially introduce confounding. Again, they tried to account for that in their propensity match analysis, but just potential for unmeasured differences between the treated and untreated patients. Additionally, they defined treatment as that new oral antihypertensive class, but they didn't include patients who maybe came in on an increased dose. And so they're potentially undercounting treated patients, but that would actually suggest that the harms associated with hypertension might be greater than what they observed in this study. In terms of takeaways, I think for at least this cohort that they looked at, non-cardiac admissions, treatment of hypertension in the hospital was associated with higher rates of complications. And as they demonstrated, intensification of blood pressure treatment at discharge did not result in better outcomes, either short-term, 30 days post-discharge, or at a year. And so I would say in the absence of end organ dysfunction for a patient who's not admitted to the hospital for ACS management or a stroke or something where blood pressure needs to be more tightly regulated for disease management, it would be reasonable to avoid treating the abnormal number while they're in the hospital and try to defer adjustment of their medications to the outpatient setting. And finally, I'll shift gears to talk quickly about hydrocortisone, ascorbic acid or vitamin C, and thiamine for the treatment of sepsis, which seemed to be a popular topic based on papers that were published within the last year. And I think the combination of hydrocortisone, ascorbic acid, and thiamine for the treatment of sepsis has been an interesting sort of intervention since the publication of a paper back in Chest in 2017. In that paper, a group, Merrick et al., had a retrospective observational study of the combination of those three agents, and they were able to demonstrate in 47 patients who received the treatment with sepsis a 32% reduction in absolute mortality risk. So a really significant treatment effect. There were, however, significant study design concerns. It was designed as a retrospective before and after study, meaning they compared patients in the treatment group at a single point in time to patients who were not in the treatment group at a different time. So a lot of potential for confounding factors. Additionally, it was a single center study, and so it begs the question, can this be duplicated? And so the treatment effect with this combination of treatment, it seems like people have been investigating this. And actually 2 papers were published in July in Chest, and they were randomized controlled trials looking at this combination of again, hydrocortisone, ascorbic acid, or vitamin C, and thiamine for treatment of sepsis. One was called the Oranges trial, and another had an acronym based on the three treatments, but another randomized control trial. And then in August of 2020, the ACTS randomized clinical trial, again, looked at the same combination of treatment in septic shock. And a paper in February of 2021 published in JAMA, the Victus randomized clinical trial, also looked at this combination in patients with sepsis, specifically ventilator and vasopressor-free days as an outcome. So just to compare these four trials, because their design was quite similar, all of them were randomized controlled trials, and they included a range of 80 to about 500 patients, depending on the trial, but blinded and mostly multi-center and larger than that initial study looking at this intervention. And they used pretty similar interventions, the ascorbic acid or vitamin C every 6 hours for 4 days, thiamine every 12 hours for 4 days, and steroids every 6 hours for a week or 4 days, depending on the study. And they had similar outcomes that they measured: mortality, changes in SOFA score, resolution of shock or vasopressors, and also potential outcomes from sepsis, things like kidney failure, mortality, and the like. And the big point to note is that 3 of the 4 studies really didn't demonstrate a statistically significant difference in any of the outcomes that they looked at: SOFA score, resolution of shock or pressor needs, vasopressor, ventilator-free days, acute kidney injury, or 30-day mortality. And the one study that did show a difference, in the Oranges trial, they saw a positive difference in the SOFA score change and resolution of shock and vasopressors. However, there was some concern about their study design because they actually, after the fact, after their data was collected, changed their primary outcome. And so again, there's some concern that maybe the results that they were seeing could have been related to some of the changes that they made in terms of their analysis after the fact. But the big takeaway from, again, 4 new papers trying to replicate that Merrick et al. Finding in terms of the efficacy of combining hydrocortisone, ascorbic acid, and thiamine really didn't demonstrate any strong or clear evidence to support the combination use of these treatments in the treatment of sepsis. So I think more studies are needed, potentially individually exploring each of those or shifting gears and looking at alternative modes of treatment. So some final thoughts, just to summarize our takeaways. So when we're thinking about empiric antibiotic selection for aspiration pneumonia, probably should not include anaerobic coverage. Consider screening for PE in patients with an acute COPD exacerbation, especially when an alternative diagnosis in terms of the etiology of their exacerbation isn't apparent. The use the shortest and most appropriate course of antibiotics for common and uncomplicated infections. Think about apixaban for treatment of cancer-associated clot in select populations. And we can also start thinking about rivaroxaban for anticoagulation in patients with AFib and a bioprosthetic mitral valve, but not yet maybe in a mechanical heart valve or rheumatic heart disease. It's reasonable to avoid treatment of hypertension in the hospital, particularly in the absence of end organ dysfunction or a specific diagnosis like stroke or MI, where we need to target blood pressure more aggressively, and instead defer hypertension management to the outpatient setting. And finally, despite many randomized controlled trials, there still is no clear evidence to support the combination of hydrocortisone, vitamin C, and thiamine in the treatment of sepsis. And that's all we have for today. Thanks so much for your attention, and we are happy to take questions at this time.
So this is Susie Glass. I just saw the question about anaerobes in the alcoholic population. They actually didn't specifically isolate out those patients, which I think is an excellent question and probably worth studying. But they didn't see that as a specific difference between the population groups when they were doing that multivariate analysis, whatever. So it's hard to know if that means it doesn't exist or if there just weren't enough patients included in the study.
I appreciate, so Matt Holland, current Washington ACP governor, and well, thank you for what a great update. And I notice Dr. Beinlich's comment and thank you for that comment. We welcome those of you who have suggestions for the chapter. And I think we should acknowledge Dr. Golapudi and Dr. Diva's, Dr. Mani's efforts in terms of thinking about organizing things like this. And so, yes, we do anticipate that. I think Divya said that there will be another one in September. I also want to highlight that this year, our annual chapter meeting, we're going to return to Dr. Frank's question here in a minute. So if our speakers and moderators want to tackle that, be thinking about that. But I want to highlight too that we anticipate that for those of you that live in communities outside the sort of Puget Sound area, we anticipate that the annual chapter meeting this year will be also offered virtually. And that includes an inpatient pre-course that Dr. Glass is one of the co-chairs of, which will be 4 hours of hospitalist-focused presentation in collaboration with the Pacific Northwest chapter of the Society of Hospital Medicine. And so we're really ramping up our hospitalist specific content in partnership with the Society of Hospital Medicine Pacific Northwest chapter, and hoping to continue to do that kind of events with them. And then again, we'll be featuring a 4-hour pre-course in November. So stay tuned for that. And then we'll also make our annual chapter meeting. Also, there will be an option so it'll be a hybrid. There'll be both an in-person and a virtual attendee option. So just a plug for those, to put that event on your calendar. And now I'll hand it back to our speakers and moderators to tackle Dr. Frank's question.
Yeah, so this is Susie Glass again. So the question was about the short course of antibiotic treatment for patients getting a fluoroquinolone in the uncomplicated pyelonephritis, and whether or not they would require a higher dose of fluoroquinolone for that treatment. They didn't specify in their study, kind of reviewing the data. So I think you'd have to go through and look at all of these studies and see exactly which dose they used. But I would say, based on kind of how I've read this and interpreted it, I do not think that they need a higher dose.
Anyone have any other questions? I think if there are no other questions, we can call it a day. Thank you so much to Dr. Glass, Dr. Zhou, and Dr. Hawes for the talk. It was great. great summary of recent evidence and actually quite thought-provoking and potentially practice changing. So we really appreciate that. As Matt said, our September session, hospital focus session, will be a goals of care workshop, but I really appreciate the idea of quarterly updates for hospital medicine. So that's something that we can definitely help move forward. So I appreciate that idea. And really, if there are any other ideas for hospital focus sessions, we'd love to hear any ideas. You can email us through the chapter email, and we're happy to help you set that up or set it up on your behalf. So if there's nothing else, I think we can say bye.
Thanks again for having us, Divya.
Bye, guys. Thanks. Oh,
Thank you.